Hello and welcome to the U.S. Healthcare Reform Proposal. This project is brought to you by Abdullahi Farah, Ndayak Songo, and Robert Mugire. America is worried that the quality of the healthcare industry is going to decline due to the rising cost of healthcare in the United States. This comes as the Affordable Care Act, also known as the Obamacare, have increased the number of people insured, which in turn may off-balance the quality of care delivered unless cost reduction policies are implemented. It is therefore quite pivotal to place more emphasis on curbing the cost in any future healthcare reform initiative. That's why this proposal or this model proposes a comprehensive reform of the U.S. healthcare financing system. Before we can model a new plan, we first need to understand the current structure of the healthcare system in the United States. This pictorial view depicts the present structure of the U.S. healthcare system. The triangle represents the flow of healthcare transactions between main parties, including the healthcare recipients. The circle on the right also does display a breakdown of the existing coverage in the United States, including the uncovered population, which are estimated to be over 40 million persons in the United States. According to the Centers for Medicare and Medicaid Services, hospitals are the biggest contributors of the rising healthcare cost in the United States, comprising 32% of the healthcare cost in 2016. This is followed by the physicians and other clinical services with a contribution of 20%, while both prescription drugs and administrative fees add up to nearly 20%. In other words, more than 50% of the healthcare expenditure of the United States in 2016 went to the hospitals and the personnel providing the care in them. Healthcare providers, including hospitals, autonomously decide how much to charge on each service or product provided to patients during their stay. These prices, which are kept in the chargemaster, is known to carry enormously inflated prices of products and services. As a result, insurance companies have to negotiate with the hospitals on the cost of the products and services, which propagates insurance companies to transfer such costs to their clients, thus driving the overall cost and the premiums higher. What that concludes is that the spiking cost of healthcare in the United States is neither due to insurance crisis nor a coverage issues, but a cascade of overpriced care by the hospitals throughout the United States. This gives our project a place to start when it comes to proposing a new model of healthcare for the United States. The main question we'll try to answer is, how can we cut the cost in half while keeping everything that already works in healthcare? What we therefore propose is eliminating the middlemen, the insurance companies, who happen to sell services that they do not primarily offer, but obtain from a third-party hospitals. Such elimination would occur in the form of merging the insurance companies and the healthcare providers as a single entity, so that insurance companies are no longer negotiating the cost of healthcare with healthcare providers, but are also co-writing the chargemaster. Such merger would drive the healthcare costs down and also make regulation a lot more feasible than it currently is. This new approach will create a competitive marketplace where consumers have plenty of options to choose from, preventing the possibility of one brand taking over the entire healthcare industry. In this new plan, insurance companies will take over healthcare providing sector and are no longer selling just premiums, but also products and services. This structure will give consumers the leisure to shop around with plenty of options and policies competing against each other in a free and open market. To particularly drive the price down, the Congress will also permit both Canadian and European insurance companies to compete in the US markets. On the other hand, Medicare, Medicaid, and other publicly funded programs will remain intact, and the government would also shop in the marketplace, granting contracts covering the publicly funded programs for private insurance companies that offer the most promising and cost-effective coverage. The federal government and its regulatory agencies will create an overview watchdog that will regulate and enforce healthcare laws to ensure transparency. It is also the responsibility of the federal organizations and the Congress to introduce and debate new laws and make amendments to enhance healthcare components in the United States. For example, the Congress will need to formulate laws that will pave the way for Canadian and European insurance and pharmaceutical companies to invest and compete on the US markets. Additionally, the federal government will still maintain to provide funding the structure of Medicare, active and retired service personnel coverage, and the Native Indian health insurance. Similar to the federal role, the states have the mandate to oversight and inspect insurance-provided healthcare. States will also be able to draft and adapt state-specific policies that would not only enhance the quality of care delivered, but also be able to initiate long-term programs that would benefit the local consumers. Finally, the states will still maintain the provisions of Medicaid for low-income families and those who do not qualify for private insurance through their employers. One of the biggest contributors of the healthcare cost in the United States is the expenditure toward the pharmaceuticals. For example, Lipitor, a prescription drug that treats cholesterol, costs like $50 in Canada, while it is $150 in the United States. That's why the healthcare providing sector, which is the insurance in this case, still must negotiate with the pharmaceutical companies for cheaper drug prices. In this new structure, the healthcare providing insurance will shop in the marketplace and negotiate the cost of drugs and medical products with a variety of pharmaceutical companies, including both Canadian and European companies. Employers will negotiate directly with insurance companies on behalf of employees for the most affordable and cost-effective policies. Employers will not limit the range of coverage and will fully comply with both the federal and state laws regarding this particular matter. Employers will offer incentives for employees who participate in preventative healthcare programs, such as physical fitness and biannual screening services. As the consumer rights expand in this new healthcare structure, so as responsibilities. Under this new policy, the consumer have certain responsibilities that are congruent to the rights stated above. Some of the responsibilities are to obtain a medical insurance, public or privately funded, to designate a primary care physician for self and family, and to report at least twice a year to routine physical and physiological checkups. This will drive down the number of uninsured persons. It will address all preventable asymptomatic diseases, and it will also decrease the number of patient hospitalization per year. Public health will address both short and long-term community health goals. This includes the creation of community, county, and state-level public health centers that concentrate on the social determinants of health. Some of the examples that are also stated in the Healthy People 2020 are the statewide nutrition programs, urban and rural health programs, education for young adults on STDs, and also environmental safety measures. Federal government will continue to fund all publicly funded programs with the exception of Medicaid, with which states are responsible. In compliance with the federal laws, employers are also mandated to provide affordable health insurance for their employees with a certain amount of out-of-pocket copay. Finally, individuals who belong to neither of the previous groups can privately and directly purchase from insurance companies. This group, who make less than 5% of the population, often are well off and are capable of affording to buy a private medical insurance. Some of the benefits of this model is that all Americans will have access to healthcare. Private insurance companies also will own healthcare institutions and be able to cut the prices, since they will not be hiking premiums and blaming healthcare institutions for the increased cost. Now, they are providing the insurance and also they own the institutions, so they can easily be held accountable. There will be more competing insurance companies in the marketplace and a variety of pharmaceutical companies, which will drive cost of product and services down. Consumers will know the cost of diagnostics, clinical and surgical procedures before deciding which healthcare institution to receive care from. The fragmented, loosely connected healthcare system with multiple stakeholders will no longer exist, as only the public and the private insurers will manage and deliver affordable quality healthcare services, and eventually, universal healthcare might be achieved in this way. No plan is perfect, and neither does this. Since this new plan fundamentally changes the U.S. healthcare system, opposition to the plan will be formidable. Advertising and creating PR for the new program will be costly. Plus, we run the possibility of one single brand dominating the marketplace with prominent financial power. So those are some of the weaknesses that we still need to think about before implementing this new model.